Okay, so if you have seen this thumbnail and you have thought, okay, I also want to become a successful intensivist, and you have clicked on this video, I will say your thoughts are in the right place, but probably you are looking for ways to improve yourself and become successful in your career. And I agree, everybody would want the same. Unfortunately, there are no magic pills which you can just take, swallow, and become successful overnight. Probably after seeing this video also, you will not become successful overnight. These are the points which I feel they are very useful, and if you inculcate in your day-to-day practice, they are going to make you successful one day. And these are the points which I have realized over many years of my experience. I have jotted them down at some points in my career, and since many months I was thinking to create such video, but I was compiling them in one place, and I used to compile them in my tablet, and now I have come up with probably the most of the points that I could recollect over past few months. And let's start, and let's do this. Okay, so first of all, first habit that I want you to inculcate is do not delay sending blood cultures. So if you are suspecting any patient to have sepsis, and it is discussed and thought that probably we should send blood cultures or any other cultures, but mainly blood cultures, because we might get some isolate some organism, and after that we'll start antibiotic and see how things go. And if you delay sending the blood cultures, then probably the treatment will be delayed and the patient will not do very well. And I have seen many times that the discussion or the order takes place at, say, 10 o'clock in the morning, and by 2 o'clock also the sample has not been taken. This is probably because the junior doctors get busy, they don't have blood cultures bottle readily available, the nurse has gone on a break. There can be various reasons, but you have to just be on that task and finish it before you do anything else. And probably that will improve patient outcome, in my opinion, and that is something which you should really incorporate in your practice. Second point is so delaying the first dose of antibiotic. So this is related to the first point itself, that if patient is in shock, patient is septic, and you feel that okay, we need to give certain X antibiotic, and but yes, we need to send cultures first, and then the cultures are delayed, and secondly the antibiotic dose is delayed. Sometimes the nurses don't order them on time. Sometimes even if order is placed in the right time, the medicines are not delivered on time. So to avoid all these issues, probably it's a good idea to keep the doses of at least 1 or 2 doses of first doses of commonly used antibiotics in your ICU, and that way whenever it is decided that this patient has to receive X antibiotic, immediately it is given to that patient. You might be interested in seeing this article which was published in 2006, where they have documented that every hour delay in administering the first dose of antibiotic in patients with hypotension was associated with increase in the mortality by 7.5%. So this is a very significantly high number, and this was during the first 6 hours that they noticed. So this itself is self-explanatory, that the more you delay, the more likely the outcome to be poor. And so it would be probably like a golden hour where we try and thrombolize patients, MI patients or stroke patients, or trauma, we have golden hours. So it is similar to that. And septic shock is an emergency, and don't delay your antibiotics just because of some silly or trivial issues. Try to give the first dose right on time, and in all ICUs they all work like a smooth machine. So once the order is in place, probably there won't be problem for the next doses. So start your antibiotic, give the first dose as soon as possible once it is decided. Okay, now third point I think is sitting on the critical values. So in one of the hospitals where I worked, we used to get calls from the laboratory that sodium is very low or very high, potassium is very low, very high, creatinine is very high, or ammonia level is elevated, or sometimes there are resistant organisms. So patient has grown pseudomonas in culture, and it is resistant to the antibiotic that you are giving. And it is sensitive to only a very broad spectrum or higher antibiotics. So when you get such information, any biochemical value or microbiological report, immediately escalate, discuss with your senior or whosoever is the decision maker. And this applies to you also when you become senior, and take immediate decision, because the more the delay, probably the outcome will get affected, and patient will not get correct treatment for it. I can understand that for creatinine or urea, if the patient has CKD or there is ongoing AKI, it is expected that these values will be high, and you don't need to panic for that. But for potassium, for ammonia, for resistant microorganisms, probably I would expect you to act very fast and swiftly rather than finishing your whole round and then going for a break, or these kind of things can be probably done in a better way, in a more efficient way. So that's my third point. Fourth is not stating the ventilatory settings on the ABG. So when I show you an ABG, for example, this is the ABG that you can see, and you can see the PO2 is excellent, and you are happy, okay, everything is normal. But if I tell you that this ABG was taken for a patient who was on 100% oxygen, on mechanical ventilation, patient is sedated and paralyzed, will you consider this ABG as normal? Probably no. This patient is severely hypoxic, you will say. So how do you come to know about this? Or say your respiratory rate on the ventilator is 35 and then your carbon dioxide is within normal range. Then will you consider this ABG as normal? Probably you will think whether you want to change any settings, or whether you want to come down on FiO2, whether you have to change the respiratory rate, tidal volume, or pressure support, or pressure control, or whatever the parameter be. So if the patient is on high oxygen, you might want to come down on the oxygen, or you might have to increase the oxygen. So if you see the ABG with the ventilator setting or FiO2 that the patient is receiving, probably you will get more information and you will see a bigger picture, and you will be able to take decision. So make sure that your staff, your nursing staff, your juniors, they all write down the ventilatory settings also when they show you the ABG. So that's point 4. Point 5, so that is, don't delay changing the block tube, or don't delay changing the leaked cuff. So when somebody tells you, some nurse might come to you, and I'm sure it might have happened with everybody. So when somebody comes to you and tells you that, okay, I feel that there is some noise here, or some noise from the mouth, or on the ventilator I can see leak, or tidal volume is not delivered properly, you say, okay, wait, I am coming, I'll see what happens. And then we delay things. It has happened with me also, and it's a common thing. But if you have suspicion that the tube is blocked, they are not able to pass catheter, or somebody would say there was a lot of resistance while passing catheter for suction, and then I put some saline or some bicarbonate, and now it is going better, and then you say, okay, so the problem is solved. But probably these are the situations where the problem is not solved, and probably you should yourself check whether there is actually any resistance, and whether there is suspicion of blocked tube, or whether there is actually any cuff leak. If you just feel that, okay, let's push it inside, most of the times the tube is not pushed straight away like that. It is bent within the oral cavity, and the cuff, if it has got out, the cuff will still remain out. If you try and fill more air in the balloon, in the pilot balloon, and inflate the cuff, then also probably if the cuff is halfway through, it might come out completely. So I would, if I get certain information like this, I would probably go myself and check that. And if I have doubt, or I'm not sure, I will probably err on the side of changing the tube, or removing the, whatever the situation be. But I will not sit on the tube when I am told that probably there is some cuff leak, or there is some suspicion of obstruction. Now, another thing also from the respiratory point of view is not auscultating the back when you take your daily round. So if you are auscultating, most of the patients in the ICU are lying flat, or they are propped up, and it's very common that we auscultate here on the sides, and we go, and okay, chest is clear, or whatever findings you get. Sometimes you even see the x-rays, and you will see normal x-ray, there is nothing. But if you look at the anatomy of the lungs, the posterior lobes, the inferior lobes are actually posterior, the upper lobes are actually anterior, and the fissure runs obliquely like that. So sometimes even in the x-ray, you cannot see certain part of the lower lobes, which is behind the diaphragm. And unless you auscultate the patients, you miss very important information. And then you obviously you come to know about it 1 or 2 days later, when the x-ray has worsened further, or when the oxygen requirement has gone up. So probably it's a part of your practice. If you don't do it every day, that will not become part of your system. And that's why make sure to lift up the patient, or turn the patient on one side, and auscultate at the back as well. Point 7 is, okay, so waiting on suspected pneumothorax. So if your patient's oxygen requirements suddenly go up, or patient's hemodynamics suddenly get compromised, and you suspect that, okay, this patient may be having a pneumothorax, which is fine. You have done your job, you have applied your brain. But now what you do? if you order an X-ray or CT scan, it is going to take a lot of time. If you have point of care ultrasound, just try and see whether you can diagnose pneumothorax. In most of the situation, probably you will not be able to diagnose. So take second opinion, take help of your colleague or your senior, and come to the conclusion whether it is a pneumothorax or not. And if it is, then immediately put a intercostal drain. Because if you sit on the potential pneumothorax, it will convert into tension pneumothorax and patient will collapse, and you end up doing CPR for a reasonably stable patient. So don't wait for X-rays or CTs. Confirm with the bedside ultrasound. Take help of your seniors or colleagues if you have doubt. But come to the conclusion. If you are still left to do the X-ray, try and just keep on calling them and get the X-ray done as soon as possible. Try and diagnose at the bedside itself when the X-ray is short, and don't delay if you are suspecting a pneumothorax. Another one is delaying extubation. So suppose the night handover person has given handover that, okay, this patient is stable, I have put the patient on pressure support and now you can extubate. I have seen many times that sometimes the registrars delay. Sometimes the round starts at bed 1 and our patient who is to be extubated is on bed 10. So it will take 1 hour or 2 hours to reach this patient, and the extubation will get delayed. By that time, patient is on pressure support or TPs, and 2-hour delay will lead to fatigue or failed extubation, and then the patient might get re-intubated. So especially for those patients who have been intubated for 1 or 2 days just for post-op care, or they don't have any chronic ventilation history, probably it is wise to extubate them as soon as you feel that they are fit. And if you are a senior and you insist that I need to see this patient before he or she gets extubated, probably it's a good idea to start your round with such patient. So the decision is taken, and probably you can come back after finishing the round and see how the patient is doing. So you know that whether your extubation was successful or whether patient needs some assistance like BiPAP or re-intubation. So don't delay the extubation in potentially extubatable patient. Okay. Now, okay. So 9th point is probably for the purist. So if you have just read the respiratory physiology, or you have read the hypoxic failure or some kind of new reading, and or you are a very purist mindset person and you encounter a breathless patient, you will say, okay, wait, let me do an ABG, let me see what is PO2 on room air, and then we will decide what to do. But probably you can do that if you have the ABG needle and syringe in your hand. You can just take sample and start oxygen. If you don't have it in your hand, or if you are relying to get ABG from someone else, it is going to take a long time, and you can't leave a acutely breathless patient who is desaturating on room air just to get your PO2 values for room air. So just start oxygen. Anyway, you can correlate with the oxygen that you are giving, whether the PF ratio based on PF ratio or alveolar arterial gradient, whatever. But don't delay starting oxygen for an acutely hypoxic patient just because you want to see the room air PO2. Okay. Point 10 is not reading the reports of imaging. So this is very interesting. So in one of my previous videos, I have recommended that we read the reports, whatever imaging is done in our unit, including X-rays, CTs of head, chest, pancreas, the abdomen, or MRIs. So that is fine. But let's see this X-ray, for example. So this X-ray was done for a post-operative patient who was extubated, and they had put an NG tube. So this X-ray was done probably just to see the position of NG tube. And it's not great. I know the exposure is not correct. It is all more like a whiteout. But if you see carefully, you can see the NG tube in the X-ray. Now everybody was happy. The tube is in place. We started feed and all. And suddenly the X-ray was reported. In some of the hospitals, if there is any urgent or any significant finding, they give a call to the ICU. In this case, we did not get call. Fortunately, one of our doctors picked this up by reading the report. And can you see the pneumothorax here? So they had reported that this patient has pneumothorax, although it was not tension pneumothorax. But we repeated the X-ray and we just gave high oxygen to this patient, and she did well and improved over the time. But the thing to note here is, you are not seeing pneumothorax in a normal or in an X-ray where you don't expect it. But sometimes the radiographer or the radiologist, they are looking at everything because they have to report the X-ray in certain protocol. And in that case, they might come across things which you may not have realized. Sometimes you may have done the x-ray for a patient, and in the report they would have mentioned that the line is too much inside the right atrium and probably you should withdraw that, or the endotracheal tube is too much inside and probably it should be withdrawn. So these are very practical problems, and if you don't read the imaging reports, probably you are going to miss these things. So please read the reports of the imaging. Try to get the reports as early as possible when it is for the ICU patient. And if you can diagnose it, it's very good. But this is for the sake of making sure that you are not missing on anything important. So please make it a habit to read the reports when you do any kind of imaging. Okay, now another bad habit I would say is not removing the old line after you insert the new central line. So I don't know what's the reason, but most of the time the reason is very silly. So you have to change the line. For example, for a septic patient, you are suspecting that the line is the source of your sepsis, and you put a new line. So say one line was in the right IJV, you put a left IJV. Both the lines are inside now the superior vena cava. They are both touching each other, and you say, okay, now I will do an X-ray. I will see the position of my line, and if everything is good, I am happy. Then we will remove the old line. The X-ray was done after 2 hours. It was reported or it was seen by you after 1 hour later. So that's already 3-4 hours after you have put a new line. Then you instruct the nurse that, okay, now remove the line. The nurse might not be feeling very confident, so she asked for help. Then the help came after an hour, and then it was removed after say 6 hours. By that time, probably your old line would have transmitted the colonized bacteria or fungi to the new line, and probably you would have just wasted the patient's money by changing the line rather than doing any benefit and getting the source under control. And probably the easy solution is when you put the lines, generally the ultrasound is standard of care, so just trace it down and see whether it is going straight. Clean the area of subclavian line also, subclavian area also, and put your probe there and see if the guide wire is going into subclavian. So if your guide wire is not going into subclavian, the guide wire is going straight like that towards the mediastinum, probably you are all right. You can take out the old line, and if there is some need to adjust position, it can be obviously done later, but you don't wait for the chest X-ray to just for the sake of seeing the position of line. You can also rule out pneumothorax when you have put line immediately. So most of the problems can be solved when you are doing the procedure itself, and it's not a good practice to wait for many hours just for seeing the X-ray and taking a decision, and then that decision is also delayed, the execution is delayed for various reasons. So don't wait when you have put a new line, try and get rid of the new. I can understand if the patient is on high inotropes or something. Probably you want to start the inotropes from the other line and then gradually taper the previous one, and so that's fine. But in other situations, probably it's always good to remove the old line as soon as possible. Next one. Okay, so this one is also very common. So you have to act very swiftly if somebody tells you that patient is hyperglycemic or hypoglycemic. You can't say that, okay, patient is hypoglycemic, give 125% dextrose, and what happens after that? So you have to repeat his or her blood sugar and check whether it is in normal range or whether it is still low, and you may have to take the decision to repeat again the glucose. Sometimes you may have to adjust the dose of the oral anti-hyperglycemics or your insulin. Sometimes it is a sign that patient's kidney function is going down, and that's why on the previous dose of diabetic medications the blood sugar level is going down. It may indicate sepsis. So when you get such information, look at the patient, think in your brain, why is it happening? Is it just because of the poor oral intake or poor nutritional status, or is it because of some other problem which is worsening your patient? If you are told that patient is hyperglycemic, most of the time the response that I have noted is, okay, wait, repeat after 1 hour and see if it is okay, then we can continue the same way. But nobody repeats after 1 hour, nobody follows up. If the nurse has done after 1 hour, they mention in their chart really nicely that, okay, I have done this, it was this much. So say it was 300 before and it came to 250 now, so it has improved. But it is your job to see that and make sure that this patient comes to normoglycemia or whatever your permissible level of blood glucose levels, and don't push them into decay. So you may need to change the fluid, or you may need to start something. Patient may be started on steroid, and that would be the reason of hyperglycemia. So there can be various reasons, but unless you spend 2 minutes and think with your brain, probably you are going to miss them, and probably next day or day after it will be diagnosed and it will do a lot of harm to your patient. So please act swiftly when somebody tells you that there is hypo or hyperglycemia in your patient. Point 13 is not talking to your patient and their families after seeing the patient. So sometimes when you start your round, the patient's attendants are already there at the bedside. So you request them to stay away or get out of the patient cubicle. You see the patient, you talk to nurse, you talk to your junior colleagues, get everything, get every information that you can, take some decision, give them some advice, and start moving and see the next patient. So the family or the attendant has seen that you have seen the patient, you have done something, you have discussed, you have advised something. They expect that now you will tell them some update, and if you don't do that, probably you are losing their trust to some extent. And it is always best, you are at your best when you see the patient and just come out, because you know everything about that patient, you know most of the numbers also really well. So that is probably the best time to talk to the patient's family also, because you know everything, you can answer the questions very well. Even the nurses and your other colleagues are also with you on the rounds, so if you are not knowing something, they can help you with that. And based on their questions, many times I have realized that okay, I have missed this thing, and when they ask or they point out that there is certain background, certain disease in the background, or certain medication on the chart which is not reviewed or not restarted or not stopped, probably relatives give you very useful information. So do talk to the patient's family after seeing the patient at that same time. So next point is not explaining grave prognosis or the risk that patient may die to a family of a very critically ill patient. So this is something which is very important, and this can reduce the incidence of violence with involving the patient's families and the medical staff. When a senior person or a consultant comes for a round, it is your moral duty to talk to the family and tell them that if the patient is not doing well, to tell them that this patient is not doing well, he or she is critically ill, and he or she may not make it. And if when you tell that very explicitly, probably that conveys the right message to the family. And sometimes when they are told in advance, they get some time to process, and then when suddenly the patient passes away, they know that okay, we were explained and we know probably why this is happening, and their reaction is not very abrupt or very aggressive. And many times I have seen that the junior staff or the nursing staff, they are not very comfortable discussing these things with the family, and it's not right to let your junior staff go and tell the family that okay, now the patient is no more, because you don't know how the family will react when they hear it for the first time. So it's always good practice to talk to the family. If you are there in the unit and some death happens, probably it's a good practice to go and tell yourself to the family and break the bad news, because probably because of your seniority, they will respond in a much better, calmer way, and probably you have more experience in handling such situation, and you might be able to handle this situation tactfully. It's a good idea to take your colleague along with you, the junior colleague, because they might see some interaction between you and the patient, and they also might improve their learning and their experience. So that's about this. Now next point is not informing references on time. This is more for the junior doctors who are doing their practice. So when you are when you discuss on rounds and you feel that okay, we need a specialized opinion from a cardiologist, gastroenterologist, or whatever, or a surgeon, and when the reference is informed late, probably later in the day the respective colleague has already left the hospital, they would take the reference on phone and they say okay, tomorrow I will come and I will see the patient, and in that period some important intervention could have been done which is missed. So try and inform the references very soon, preferably in the initial time of the day itself. Try and discuss something important. If you want to do a say radiology guided pigtail insertion, or you want to aspirate an abscess or collection, or you want to send the patient for reoperation, patient is bleeding and you feel the source of bleeding is surgical site, you need to, the senior most person should speak with the senior most person on the opposite end and try to convince them and get the decision very fast, rather than you telling your junior telling their junior telling the surgeon, and eventually the message getting diluted in the whole process. So please inform the references on time. For important things, please speak directly to the relevant consultant and get the job done as soon as possible. Okay. Now, another important thing which one of my colleague pointed out, that is that when any new equipments come to your unit, it may be a new defibrillator, new ventilator, it may be a new monitor, or it may be your dialysis machine. Don't get comfortable until you are familiar with all the functions and you are confident in handling that machine in emergency situation. I know there are certain ventilators where you can select your inspiratory to expiratory ratio, and whenever you change the rate, respiratory rate, tidal volume, anything, the ratio remains fixed. There are certain ventilators where you have to select inspiratory time rather than the ratio, and the ratio is then based on your inspiratory time. So if you increase your respiratory rate, the inspiratory ratio is changed. So at the same time, if you want to maintain the ratio, you have to change the inspiratory time also. So this is just one of the examples of the things which I want to convey. So try and figure out how the machine works and how it is different from the previous machine which you and the whole unit was very comfortable with. And unless you are very probably you can organize a demo with the technical person from your hospital or from the vendor, and you may have to organize 3 or 4 sessions, because every time everybody may not be able to attend them. But it is always a good practice to get familiar with a new equipment, and it is always a good practice to have the instruction manual or user manual handy whenever you are in any doubt. But I don't think it will be helpful to read a user manual when you land up in emergency trouble. So make yourself familiar, be confident about the machines that you have in your unit. And the last one is, probably you might find it silly, is you need to leave the unit after your handover is finished and the next person has come, or after your round is finished and you have done your job for that day. It's not, I know it's very interesting, there are a lot of interesting things going on. Sometimes you just want to vent out your anger or your frustration for your shift, and that's fine. But if you keep on lingering in the unit for a long time, since it is an intensive care unit, there will be some kind of emergency or some disaster happening at some place or another. And if you are there, you are found there, probably it will be your ethical duty and you will have to join that, suppose for a CPR or for a new line or for an intubation or whatever. Or there might be entry of some dramatic consultant who might start creating drama, and in the flames of that drama, you might also burn your finger unnecessarily, even after giving handover. So please leave the unit as soon as you finish handover. So these are only some of the points which I could think of, and I try to compile them in one place, and I am making this video. Probably you might think of some other points and just include them in your practice. These things are habits actually, which are formed over many days or months, and they are not something which you can improve on in just 1 or 2 days. So make these habits. If you start your career, probably that's the right time when you can make right habits, choose right habits, and start your practice in a right way. So please incorporate this. If you have any more suggestions of which habits we need to incorporate or inculcate in our practice, please write down in the comment box. And for the next video, please like this video, subscribe to the channel, hit the bell icon. Until the next video, bye.